Welcome, everybody. May have a couple more people join us as we go along, but we'll get started here. Just going to share my slides. Again, sorry. All right, hopefully that's coming up for everyone. So welcome to today's webinar. My name is Melissa Linsman. I'm the Primary Care Transformation Lead with the Middlesex London Primary Care Network. We're very pleased to have Kathleen Klement with us here today to talk about practical foot care referral pathways for primary care. I just have a couple things to go over before we start. Sorry, I don't know why it's not. And just to mention, I know we normally use Zoom for these webinars, but today we're trying to use Teams. So please forgive us if we have any sort of hiccups technology-wise. We'll try to get everything else sorted. But just a reminder, please stay on mute if you're not speaking. There is a raise hand button to ask any questions. You also all have availability to write anything in the chat feature, and you'll see that along the toolbar at the top. Actually, I can see everybody's name, so this is one advantage of Teams, that you can actually rename yourself. So after today's session, we'll send out your main pro certificates to your email that you registered with. And just a note, this meeting is being recorded, and we'll have all the recording and the slides available on the MLPCN website. Our website there is also where you can go to confirm your membership with the MLPCN or sign up to hear about future events like these webinars. It's just a quick slide about what the MLPCN is. So what we really do, we exist to empower primary care, and we want to ensure that those of you who are providing primary care also feel cared for and supported and heard. So quickly, if you aren't a Middlesex London Primary Care Network member, you can do so on our website. The QR code is there as well. I know a number of you who are on are already members. Just to go through today's learning objectives. So by the end of this session, you should be able to enhance your understanding of foot and lower limb care in the primary care setting, gain practical knowledge to make evidence-informed referrals, identify appropriate providers for common conditions, and apply effective referral pathways that support interprofessional collaboration. We as a program, we receive in-kind financial support from Thames Valley Family Health Team, as well as the Middlesex London Ontario Health Team, as regards to administrative and logistical support, and we don't see this as posing any conflict of interest. Then I'll just have Kathleen go over her disclosures.
So my name is Kathleen. I am an employee of Soul Science, but I haven't received any financial or other support in relationship to this program today.
Thank you, Kathleen. We have your bio here a bit, that it was provided in some of the promotional things for this webinar. But I'll stop sharing and let you pull up your slides. And thank you so much for being here with us today. And
Perfect.
sorry, just trying to figure out how to stop sharing.
I just gotta find the sharing settings again because I am brand new to Teams. I don't see the share button again that I did earlier. It's grayed out, so I think you have to give me permission to share my screen.
You should be able to now. I changed YouTube back to a presenter, I believe.
There we go. Okay, so hopefully everyone can see my slides there.
Yep, we can see them.
Perfect. All right. Well, hello everyone, and thanks for joining me today. I'm Kathleen. I'm going to walk you through some practical evidence-informed pathways for making some foot care referrals in your primary care settings. And as Melissa already mentioned, the overarching goal for today's session is to improve that patient access and outcomes and confidence when those patients are navigating the foot care landscape with you alongside them as their primary care provider. So what we'll be covering today is I'll briefly start off with just some foot care landscape pieces, so including the providers and their scopes. And then I'll move into a few details about insurance and funding considerations, and I'll touch on the various agencies that might provide coverage or financial assistance to patients in the area. The bulk of the session, though, today will focus on 4 common primary care presentations, what I've heard in my experience from clinicians like you, as far as what you see in office most commonly. And I'll discuss those referral pathways, how to reduce access barriers, and just some key takeaways that you can apply in clinic immediately. So, as I'm sure we all agree, foot health plays a really big role in mobility, independence, and quality of life for all patients. And early interventions in many situations can prevent complications, especially in older adults, those with diabetes, neuromuscular disorders, or patients with limited mobility. Primary care is often the first place that these issues are identified, which makes your role as the primary care providers that initial pivot point for care and referrals. So first, let's differentiate a little bit between the common foot care professionals you'll see in the community. So the foot care world includes pedorthists like myself, chiropodists and podiatrists, which are slightly different, and wound care nurses or community practice nurses and orthotists. So each of these professions has its own scope and strengths and ideal referral scenarios. The key differentiations to make are in where each clinician has their focus for their practice or where they really shine. So let's start with orthotists. Orthotists have a whole body scope, and while they certainly do make custom foot orthotics, they're more focused on whole body intervention. So they have kind of a wider lens, and they use their broader skill set for more patients in different ways. Orthotists, however, are imperative in management of a patient with a neuromuscular deficit that might require something like an ankle foot orthosis. So they have their role and their place in the foot care realm as well. Chiropodists and podiatrists can assess, diagnose, and treat foot and ankle conditions. The focus of their practice is typically more medically focused, though, as they are clinicians that are able to diagnose as well as perform skin and nail procedures and treatment. Chiropodists are the top choice typically for referral for any skin or nail concern that you can't handle or don't have the resources for in your own clinic. Many chiropodists can and do manufacture orthotics, but it's common for chiropodists to use an external manufacturer if they choose to include orthotics in their practice. This is relevant when timelines are a higher priority for patients, as it sometimes can take weeks to receive their devices, and devices may not be adjusted or modified on site and result in another delay if any adjustments are necessary. So which brings us to pedorthists like myself. So we can assess and treat conditions of the foot and ankle, but we are one of the few healthcare professionals specifically educated in the assessment, design, fit, manufacturing, and modification of both footwear and foot orthoses. What we don't do, however, is treat skin and nail conditions, or we also don't formally diagnose foot and ankle conditions. We often assist primary care in figuring out what's going on by virtue of our detailed assessment, but we can't formally communicate a diagnosis to the patients directly. And the other key player here is nurses, both community care nurses and wound care nurses, with various levels of basic or advanced training in wound care. These nurses are an absolutely essential part of the community care system from which patients receive local wound care, often in their homes, sometimes in a clinic setting, and sometimes that skin and nail care maintenance is also provided by these nurses. So as you can see, there's some overlap between all these foot care providers, but also some key differences. So understanding who does what can help to improve care and access and reduce those delays. So this chart here I've made up kind of outlines more specifically the tasks and roles and treatments provided by various foot care providers. I think the check marks and X's are pretty self-explanatory, but I want to note what the asterisk indicates here. And that's where the clinician is educated in this area or able to provide the corresponding care or service, but it's something that's not universally applicable. So, for example, the most relevant example here is the manufacturing and adjusting of orthotics. So even though they're often trained to do so in their basic training, many chiropodists don't have equipment on site to make adjustments. And so they may need to ship the patient's devices away to be modified, or they may just be limited in what they're able to do modifications wise. So as you can see here, there's both significant areas of overlap, but also distinct differences in how different clinicians who provide foot care services in the community can serve our mutual patients. So I want to touch on fees because it's always a question that we get from every audience, whether it's patients, referring clinicians, primary care providers, insurance companies, all kinds of audiences. Across Ontario, the prices are going to range, of course, but orthotics typically range from $500 to $800 per pair. And while many clinicians include the assessment, follow-up, subsequent appointments as part of that service, not all do. So it's important to differentiate with the clinicians in your network, in your local area, to make sure that your patients are informed of those fees. When a patient isn't a candidate for orthotics or elects not to move forward with them, there typically is a fee for the appointment at a cost typically ranging from $60 to $120. These aren't set in a schedule or a fixed rate across the province or across Canada. So it is, again, best to check with the individual clinics or clinicians to make sure you have the most up-to-date information. Speaking to Soul Science as the example, the only example I really can speak to accurately, the cost of our custom orthotics is $5.99. The assessment fee is $90. The assessment fees only charged at the initial assessment, and any of our subsequent appointments or follow-ups, adjustments to the orthotics, consultations for additional pairs of shoes or just questions that the patients have, diabetic foot screening, ongoing just routine appointments are at no additional cost to the patient. Many clinics operate this way, but not all do. So I can only speak to what we do, but I know that many do offer something similar. Other products and services typically priced according to either the complexity of the service or the materials cost. So for example, footwear modifications for patients with a leg length discrepancy or some kind of foot deformity or condition that requires modifications to footwear. Those costs can range pretty widely, from $75 at baseline to upwards of $250. Those higher prices are reflecting those large complex shoe lifts because these take a lot of material and a lot of clinician time in the lab. So they're priced typically according to that. Now, skin and nail appointments, as not a service I provide, but typically provided by foot care nurses, chiropodists, podiatrists, are going to have fees that vary depending on the services provided, the recurrence rate, and the complexity of the patient, of course. Okay, so now I'm going to talk about one of the most common topics I discuss with patients probably on a daily basis, and that's insurance. So insurance coverage varies absolutely wildly, and can also change over time as policies are revised. And this is something that can be really frustrating for patients and impossible for you as primary care to discern. But we can help people navigate their policies just by knowing some of the terminology and some of the common practices. So by and large, most employer-provided insurance plans, so some benefits through your work, have some kind of coverage for custom foot orthotics, but each policy is going to have its own parameters. Some policies will be based on calendar year, for example, others will be year to date. Amounts covered are going to vary, with some policies covering a percentage, sometimes up to a cap. Other policies at a set coverage amount. Others will say customary pricing, which is the most frustrating because we don't know often what their customary pricing is until a patient inquires. Most plans, I dare say all plans, require some specific documentation, and patients need a prescription for each claim. Many policies also dictate which type of clinician is eligible to be the prescribing clinician. Typically, physicians, nurse practitioners, and chiropodists or podiatrists are included in those eligible clinicians. Some insurance policies require a physician specifically, some require a specialist. Most of them have revised their policies to include nurse practitioners, which is an incredible change for accessibility. But insurance policies rarely accept prescriptions outside of physician, nurse practitioner, or chiropodist. It's also often daunting when patients see the list of kind of quote unquote required paperwork when they read through their policy. And they'll often come into appointments or call into our office with this long list of things like raw materials and casting technique, lab invoice, work order, gait analysis. The list can be daunting. These elements are all provided by a clinician who manufactures orthotics. So chiropodists, podiatrists, pedorthists like myself, and orthotists should be very familiar with this entire list, as this is part of our typical assessment and charting procedure, essentially. So we provide those details to the patient so that their insurance company can check those boxes to ensure that it is a valid and legitimate claim. To be blunt, it's to prevent fraud, to make sure that the patient is getting a custom-made device made from raw materials, made from a three-dimensional representation of their foot. Now, that doesn't have to be a plaster cast. It can be a plaster cast. It can be a foam box impression. It can be a digital scan. What it can't be is just pressure data. So insurance companies don't accept orthotics made from solely two-dimensional data. But again, these elements are all very standard and we are very familiar with them on our end. When it comes to billing, direct billing is probably the single most common inquiry related to insurance that we get. And by and large, orthotics can't be billed directly under many policies. The insurers require the patient to pay and submit for reimbursement. Now, exceptions to this are going to be the agencies that I'll talk about next, but the direct billing piece usually comes from employer-funded or occupation-related insurance policies. So companies like Manulife and Sun Life, Canada Life. So typically they do not allow for any direct billing. So we're not even able to do it. It's not that we don't want to necessarily, it's that we can't. So orthotics, compression stockings, footwear, and other related foot care that is outside the scope of nursing basically is typically not covered by OHIP. So some of the skin and nail care is sometimes covered by OHIP, but basically everything else, no OHIP coverage. So in essence, that skin and that medical management of foot care might be covered, but most other services are not. Okay, so let's talk about some of those agencies I just mentioned. So for patients with financial barriers, funding may be available through agencies of which they are a member or a qualifying demographic. So WSIB, ODSP. Right now. Sorry? Oh. So WSIB, ODSP, NIHB, and DVA. Also, in some cases, the Southwest LHIN has programming and financial funding options for patients in certain subsets. So knowing and understanding these pathways can make that access so much easier for patients. So we'll go through them kind of briefly each. WSIB does fund footwear, orthotics, footwear modifications, bracing, but it's all done on a case-by-case basis. So typically in these cases, the patients would book an assessment appointment with us and the clinician would send off an estimate for approval. These cases are always at the discretion of the case manager or nurse manager. And typically, in my experience, they're not difficult to get approval from as long as it's a foot and lower limb injury and it's justifiable, right? I'm not going to have a patient with an elbow injury come in for foot orthotics. So ODSP is another one that is a common funding stream for some patients. So they do also provide coverage for clients receiving benefits from the program via another branch called discretionary benefits. So these benefits, processes, and requirements vary a little bit between counties in Ontario, which can be a little difficult to navigate if your patient doesn't live in Middlesex County. The processes are a little bit different in like Huron and Elgin, Wellington, and Chatham-Kent, but by and large, they cover orthotics at a set amount of about $400 every 3 years or 36 months. So speaking specifically to Middlesex County and the City of London, which are actually distinctly different in how the paperwork goes, coverage is $400 every 36 months. For Middlesex County residents, it's all done online as far as the paperwork is concerned. For City of London, it's done primarily by fax. So again, the patient would come in to see the clinician. We would send off an estimate with the referring physician's prescription or nurse practitioner's prescription, and then we would wait for approval. Middlesex County, we would send a letter to both the patient and the clinician. City of London will send a voucher to the patient. So it's functionally a coupon that they pay for their orthotics with. So there are some limitations timing wise on those vouchers. So they're valid for 60 days, but we always work with the patient to make sure that things move along in a timely process. So another big one in my practice and in this area is non-insured health benefits for Indigenous Canadians. So this funding is done through Health Canada, but clinicians have to be registered providers for the program in order to facilitate and access this funding. So it's best to have the patient or perhaps an administrator call to confirm with specific foot care providers ahead of any appointments to ensure that the clinic and the provider is registered with NIHB. Again, speaking only for Soul Science, all of our locations and all of our providers within all of our locations are registered to serve the NIHB patients. And all of that paperwork is done on our end. The patient has to do essentially nothing once they're in our office and we've determined that there is a reasonable need for orthotics and they have the prescription. We do all of the paperwork with NIHB directly. So there's not that, that barrier to access if the patients have to navigate the paperwork. So the Department of Veterans Affairs and Canadian Armed Forces also provide coverage for both active and retired members. This is all done through Blue Cross. And again, in this scenario, providers have to be registered with Blue Cross in order to serve these clients. So again, I believe Blue Cross has a database though that you can look up providers in. The client may have to access that, log in with their policy or their K number in the case of the Canadian Armed Forces, and find a registered clinician in their area. Now, there is a relatively new, very limited funding program that has recently been made available for patients in the Southwest Regional LHIN who have an open active diabetic foot ulcer and are currently receiving home care for their wounds. So this is a one-time funding opportunity. It's assessed on a case-by-case basis, and patients must have no alternative means for funding to access these services. Again, this is another piece where the clinician, like myself, I see quite a bit of this because of the subset of patients that I see with diabetes. But it's, again, something that we do the paperwork for, send off for approval, get the approval back, and invoice directly. In all of these cases, whether it's private health insurance or any of these agency coverages, a prescription is required for funding to be approved or accessed or processed. Okay, so let's look a little bit more at these common presentations in primary care. In my 15 years of practice, primary care providers have reported to me directly and indirectly some of these common foot concerns that they tend to see in clinic. And those are heel pain, diabetes-related complications, bunions plus or minus pain, and skin and nail conditions. So for this next segment, I'm going to focus on these 4 presentations with the aim to provide some broad strokes information that might apply to other scenarios, but to focus on what can we do for these folks when they present in clinic. Now, each of these scenarios or conditions, presentations are going to have their own kind of red flags and referral considerations. And as with everything, every patient case is going to come with its own set of patient-specific factors. But that said, let's look at some of the commonalities. So starting with heel pain, this is the single most common foot ailment or condition that we as pedorthists treat and manage. And in these cases, the history is one of the most important pieces. So the onset, duration, and progression of the patient's pain, combined with the presence of specific things like morning pain or startup pain, any correlations with an activity or a job change, or a footwear change, are all factors in the incidence and reason why patients are presenting with the heel pain. So on physical exam in office, you can do some very rudimentary palpation of the plantar fascia, palpation of abductor hallucis, and palpation of the plantar fascia at the medial calcaneal tubercle. And this helps to differentiate plantar fasciitis, which is the most common cause of heel pain, from other causes. So reproduction of pain in these areas usually suggests plantar fascia involvement, and being an overuse injury, plantar fasciitis is very common. So our usual suspect, plantar fasciitis, is that super common cause of heel pain that we see in clinic, and I'm sure you do too. But there's a distinct difference between how it's best to manage these cases, depending on how acute or chronic the pain has been. So in the acute phase, typically 4 to 6 weeks or less, the pain is usually more of an inflammatory process. The patients might describe sharp, stabby pain, particularly with those first few steps in the morning or after rest. And early management here focuses on very conservative things like rest, stretching, changing shoes or wearing shoes in the house, and things to provide immediate and short-term symptom relief. Once those symptoms, though, persist beyond 6 weeks, it's considered to be more chronic fasciopathy, and the inflammation gives way to some degenerative changes in the fascia. And at this stage, management is best shifted towards mechanical support. So using things like custom orthotics, progressive loading exercises, sometimes other adjunct therapies like shockwave or night splints are sometimes used. In rare cases, I like to say rare because I'd like it to be rare, cortisone injections are used. They have very different effectiveness rates amongst different patients. Some people find that they have no effect whatsoever, and some people swear by cortisone. So it's tough because it's not as universally applicable, and it can be a very painful intervention for patients. So I personally try to steer folks away from that as long as possible if other options haven't been exhausted. So let's look at some of those other options. So things that you can touch on with your patients in office when they present with more acute heel pain is what we refer to as our rest protocol. So doing things to reduce the morning pain, we have a very specific tissue-focused set of exercises and stretches that, if done regularly, daily, every morning before the feet hit the floor kind of thing, can dramatically improve acute symptoms if they're initiated early. We actually have a patient handout and a whole book that we provide at absolutely no charge to anyone, doesn't have to be our patient. And we provide that routinely to primary care offices so that you have that resource on hand. So if that's something you're interested in, I can absolutely provide that for you at any time. I like the pamphlet best because it's very easy. Here's the things to do and when to do them through the day. So E in REST stands for evaluating current activity. So for my patients, I talk about their recreational activities and occupational tasks. So determining how much the patient is standing and walking or running, how much mechanical load is going through their foot with the activities of daily living, and then make a plan or strategize to reduce some of those activities or modify duties and tasks to just temporarily alleviate some of the stress in the tissue to allow it to heal. So the S is for shoes. So it's not just about wearing shoes, but wearing shoes that fit properly and function appropriately. So selecting shoes that fit correctly, support the arch, and redistribute load is really imperative here. Good footwear really sets the stage for recovery, and going barefoot in acute pain cases and chronic, even indoors, can contribute significantly to setbacks and recovery time. And finally, T, so trying off-the-shelf solutions. such as plantar fasciitis sleeves, over-the-counter insoles, there's gel heel pads, and several other products. They can be a really good starting point. And if the basics aren't sufficient, so if the rest and activity modification, shoe upgrades, and off-the-shelf solutions just aren't enough, then this opens the door for kind of stepping up the game and considering things like custom orthotics, night splints, more focused one-on-one physiotherapy, or other adjunct therapies to support healing. So referral here is appropriate when that pain has already lasted more than 4 weeks, is significantly limiting activity or affecting their job, or when conservative approaches have failed, or if the patient has a similar recurring history. So sometimes patients will have had bouts and bouts of this heel pain that, persists for 4 to 6 weeks, goes away, persists for 4 to 6 weeks and goes away. In those cases, sometimes they just get really tired of dealing with that foot pain and they want a little bit more to prevent it from coming back. Okay, so moving on to diabetes. This is my wheelhouse, so I can talk all day about diabetes. Complications aren't strictly tied, though, to duration diagnosis. And this is one of the most important pieces that I try to drive home in these presentations, because early detection and implementation of good foot care habits and footwear habits can dramatically reduce the risk of complications over time. And early implementation and education dramatically improves outcomes. Tons of research base to support this. So the earlier we can get patients forming good habits with their feet, the better off they'll be in the long run. Screening is key. It allows us to detect those small changes before they progress and become big problems. Most foot care clinicians can and do and will conduct foot screening regularly for patients with diabetes, regardless of risk level. I use the tool that I'll discuss in a couple slides with literally every patient with diabetes. It doesn't matter if they have no foot symptoms whatsoever or no complications. I like to be very rigorous with the screening to make sure that we're just staying on top of things to avoid complications. In office, other things you can assess to further inform the risk level is vascular status. So pedal pulses, cap refill, visually looking at the foot to determine any vascular compromise or venous disease. Range of motion. So physical changes in range of motion of the foot are predictive of foot complications, specifically range of motion of the great toe at that first metatarsal phalangeal joint. So noting differences there can be very accurate in predicting potential complications. So it's an easy thing just to check the range of motion of the great toe and see if there's a big change from the previous visit. Neuropathy can be assessed via monofilament testing, and self-care ability can be assessed with your typical patient interview to determine next steps. So in these self-care cases, vision and mobility really matter. So the ability to see their feet and the hip mobility to be able to get at their feet can significantly affect a patient's ability to engage in that daily preventative foot care. So with diabetes comes retinopathy as well as neuropathy. So if they're not able to see their feet, they may need more help in caring for their feet. So management for these cases often, as I've already mentioned, includes that regular screening, routine maintenance, skin and nail care, footwear education, and pressure management through devices or footwear or orthotics. Referrals indicated when there's structural changes in the foot, if there's been a skin breakdown or injury or a wound, any presence of neuropathy, any significant vascular changes, concern with the fit or function of the patient's footwear, especially in the cases of even mild neuropathy. These folks tend to wear shoes that are too tight so that they can feel the shoe on their foot, but that can lead to trouble with pressure and friction, leading to skin breakdown. Also, if there's a history of an ulcer, even if it's healed, or a Charcot change, or if you've identified any significant gaps in education or adherence to treatment, then it's a good indication that a referral to a foot care specialist can be helpful in that case. So primary care can do a lot in office to triage patients with diabetes and make those evidence-informed referrals early. This is the screening tool. I'll go over the next page, actually. So this screening tool here is what I use on a regular basis to this is what I use for every patient with diabetes. It's designed to be a quick, standardized screening of the feet, both right and left, and it helps classify risk of foot complications, including ulcers, infection, amputation, in patients with diabetes. So as a primary care provider, you can use the results of this screen to inform when and to whom you refer your patients. So after you complete the screen, and it's a straightforward set of assessment tools, the highest score from either the right or the left foot is used to assign a risk category. I know the print's a little small here, but you can find this on the Wounds Canada website, and I believe also on Diabetes Canada. Each category comes with recommended screening intervals and actions for referrals. So for example, a very low risk patient, the recommendation is to screen yearly, focus on education, footwear, and self-inspection. So daily foot inspection. Moderate to high risk, the screening interval increases. So every 6 months or 3 to 6 months or sooner. And here there's an increased need for specialist referral. And then an urgent risk level, so active ulcer or infection, that's an immediate specialist referral for limb preservation. And if the screening uncovers a loss of protective sensation, that alone raises the risk and suggests the need for foot care referral. That alongside any presence of peripheral arterial disease, foot deformity, or other clear indicators that there's something not quite right with the feet. So this tool really gives you those specific indicators and then specific referrals to make. Even if you're not making an immediate referral, the elevated risk does suggest that more frequent monitoring and patient education is necessary. And then you reassess that need for referral on an ongoing basis. Okay, so let's talk now about a bit of a fun one, bunions and forefoot pain. So patients often present just with a bunion that might not have pain, or with forefoot pain and a small bunion. So with these presentations, I always start by clarifying the story behind it, so to speak. So finding out when the change first started, if it's been progressive, is it a recent flare-up? As a foot care specialist, we want to know about symptom duration, if they've changed their footwear, if they've started a new activity, for example, more walking or standing or a new fitness routine, but also about family history. So bunions are also often hereditary, and understanding that background really helps to set the expectations of how much we'll be able to do to slow the progression. And then also, of course, the biomechanical factors. So flat feet, hypermobility, or previous injuries can all shift load in the foot and accelerate deformity. So on exam, you can observe both feet weight bearing and non-weight bearing to look for those physical visible deformities. So hallux abductor valgus, where the hallux itself is drifting towards the lesser toes, hammering, clawing, or splaying of the toes, as well as the actual formation of the bunion itself. So bunion and hallux valgus often used interchangeably, but are distinctly different. You can have hallux abductor valgus without a bunion and vice versa, but they do often occur together. Your assessment can also include checking that range of motion at the first MTP. Limited dorsiflexion at that first toe joint can increase pressure on the forefoot and contribute to some of the mechanical cause of a lot of cases of forefoot pain. And then palpating the metatarsal heads, intermetatarsal spaces, check for neuromas or capsulitis. You can perform a forefoot squeeze to check for what's called a Mulder's click if a neuroma is suspected. But these will tell you where pressure is being transferred. And finally, a footwear inspection. So you can look at shoes that are too narrow or pointed, and they will tell you where symptoms may be aggravated. So a good visual here for the progressive stages of hallux valgus or bunion deformity from mild to severe. In that mild stage, we do see a slight lateral deviation of the great toe, but the joint alignment is pretty preserved on X-ray. In the next stage, you can see the hallux begins to angle more noticeably, the metatarsal head becomes more prominent, and that soft tissue irritation or bursitis often starts here. As it progresses to a larger deformity, the first and second toes are crowd or overlap, and the MTP joint alignment deteriorates, often with that subluxation actually visible on imaging. And the final image on the right there, there's significant angulation and joint degeneration, often with rigid deformity, crossing toes, hammer toes. And at this point, conservative management is usually limited to symptom relief, and surgical referral is sometimes indicated in these cases. So this progression really highlights the importance of early intervention with proper footwear, mechanical support, and referral when the deformity is still flexible. We can slow down or prevent some of these advanced changes. For asymptomatic or mild bunions, our focus is always on prevention and comfort. So we want to maintain the joint mobility, keep the patient active in comfort, focus on strengthening when possible, and decrease the risk of rapid degeneration. When the bunions are symptomatic, when there's pain added into the equation, we start usually with simple things like off-the-shelf or custom orthotics, toe spacers and splints to help to encourage a better alignment of that toe and more effective movement. When other forefoot symptoms are present, like burning, numbness, tingling, we often need to dive deeper to determine those mechanical causes, and sometimes additional diagnostic testing is needed to rule out neurological conditions or a neuroma, or if we need to make more dramatic changes, imaging can be really helpful. But when a patient presents in your clinic, you can start off by the footwear assessment. That's a big piece. I usually tell people in office and with my patients is there's 3 factors that affect your forefoot pain or your bunion pain: mechanics, genetics, and footwear. We can't change genetics. We can change your shoes, and we can alter mechanics. So footwear is very straightforward and something that you can offer in clinic as far as advice, encouraging footwear with a wide toe box, supportive midsole, and minimal forefoot tension or compression usually can alleviate a lot of discomfort. In early cases where the foot and mobility is still maintained, the foot mobility and toe mobility is maintained, exercises, intrinsic foot exercises, toe spacers, and things like that can help to maintain alignment and reduce irritation. And when conservative recommendations are insufficient, or if there's a large deformity, significant pain, or there's been a rapid recent joint change, or the patient's having a hard time finding shoes on their own to accommodate the shape of their foot, that's when a referral for footwear plus or minus orthotics is warranted. But referrals for footwear specifically are appropriate even in mild cases, and this is where prevention is paramount. We want to reserve the referrals to orthopedic surgeons to when the deformity truly needs surgical correction, and get patients in with mild and moderate deformity, maybe plus or minus pain, early, and get the footwear and mechanical factors sorted early, and ideally prevent the deformity from becoming rigid. So early referral before the deformity is rigid tends to yield better outcomes for patients in the long run. Okay, let's look at the 4th and final condition set here. So calluses, corns, and skin breakdown. So these often relate to biomechanics or footwear or comorbidities for the patient. So again, we're going to ask in our history about onset, duration, and progression. We want to determine if the calluses are a result of a slow buildup or a sudden change. So here again, activity, job, and footwear changes can shift pressure or cause friction that produce calluses or corns. But screening for comorbidities such as diabetes, autoimmune conditions, vascular disease, neuropathy, allergic reactions, those things can help to guide what's going on and kind of get to the root of the issue with the skin breakdown. So on visual exam, looking at the skin thickness, the surface area of the calluses, and the quality. So how thick is it? Is it flaking? Is it cracking? How long does it look like it's been there? Checking also for fat pad atrophy or shift. So this is more common under the metatarsal heads than it is at the heel. But as patients age, that fat pad can shift into the sulcus towards the toes and really expose those metatarsal heads, which can contribute significantly to the formation of calluses. And always, of course, considering risk factors, diabetes, mobility, vision, and that self-care ability. The risk level is the most important piece here. Low-risk patients can self-manage, whereas high-risk patients are going to require more clinical care. So in office, you can consider a few options for conservative management. Again, for those low-risk patients, we can encourage self-care management. That might include over-the-counter creams with urea or other deep moisturizing agents, pumice or daily skin maintenance. It's always a good idea to review the patient's support system here, determine if they're able to manage their foot care on their own or if they need help and if they have help at home. So do they have family? Maybe they have a PSW coming for another health condition that you could piggyback some of that foot care onto that existing resource. But indication for referral largely depends on the severity and the type of skin changes. So I've kind of labeled these in that red, yellow, green for level of severity. Open wounds or preulcerative lesions need an urgent referral to local wound care. So that's not something that I can manage in clinic effectively. So a referral to a chiropodist or a wound care nurse is indicated here, or if you don't have services and resources available in your clinics. For painful or disruptive calluses or corns, an acute referral to chiropody for skin and nail care is the next best step, plus or minus pressure management. So for minor calluses and fat pad atrophy, a preventative referral for orthotic consultation and footwear advice is indicated. And those referrals are also indicated for painful or disruptive calluses once the skin care has been implemented. Implementing the skin care is the most important piece, and then preventing those corns and calluses from forming back again is where the footwear and orthoses consultation comes into play. So the key here is matching the referral urgency and risk level and the functional impact to to who you're referring the patient to. Starting conservative but acting early are the key messages here. So here's just a simple one slider on the four main referral pathways that I've talked about today. So heel pain, by and large, you want to look at that duration, the pain, and the history. So if it's been more than 4 weeks or if function is impacted, that's an indication for a referral. For diabetes, refer for structural changes, any neuropathy signs, vascular issues, or skin integrity concerns, or footwear concerns. So if you see a patient with footwear that you just don't think are a good match for their feet, that's an indication for a referral. But the 60-second screener here is an excellent guide for evidence-informed referrals. So you can use that with great confidence in that, we can do these set of screening protocols, get a level of risk, and know where to refer them next. For forefoot pain, whether or not it's a bunion, refer for deformities, rapid progression, or significant pain or limitation. So the pain or limitation can be pain in the joint or from footwear. The limitation can be in doing their activities or finding footwear. For skin and nails, refer for open wounds urgently for wound care. Refer to chiropody for those painful lesions. And for patients at low risk or with minor concerns, refer those patients for conservative management with orthotics and footwear. So now that we've talked about kind of the when and why to refer, I want to touch briefly on referral notes and prescriptions. So not everyone needs orthotics long term, but there's value in that prevention and risk management. So once you've decided a case warrants a referral, focusing on the symptoms and probable diagnosis rather than on foot morphology or type or anatomy is best practice. So specify the diagnosis if known, but also include relevant comorbid conditions or any diagnostic findings that have, even if they've ruled something out, they're useful for us to know. For cases where the diagnosis or condition is unclear, patients don't need a referral from you or any other clinician to access a consult for orthotics and footwear. Patients often self-refer, and you can advise the patient to seek an assessment with a Pedorthist or another foot care clinician and request a detailed report back from that clinician. We love to provide our assessment findings. We are foot nerds, so we love giving you a detailed report on everything we've found and working with you to find the root of the cause of the patient's concerns. If we recommend footwear, orthotics, or bracing or another product or service, we will help the patient communicate with primary care if a formal prescription is needed for insurance or for funding. So patients don't have to come to us with that referral. It's helpful. but it's absolutely not necessary. And we are happy to work with patients to access whatever documentation is needed for their insurance company or funding stream. Generally speaking, insurers do require a condition, diagnosis, or injury to be clearly stated on that prescription. So terms like foot pain or pes plainness or fallen arches don't qualify for insurance claims. So instead of foot pain, we need to call it what it is. If it's plantar fasciitis, for example, or tendonitis. Pes plainness, unfortunately, not all flat feet need orthotics. That's not a reason to refer for orthotics. Painful flat feet is another matter, but then we need to find the root of the cause of that pain. So making sure that the referral notes are clear just helps patients that process of the insurance claim go much more smoothly. So one of the biggest ways that we can improve outcomes for patients across healthcare providers is by helping patients access the right care at the right time. And a lot of that's going to start with you in primary care. So first, of course, we want to offer those conservative in-clinic care whenever possible. Simple interventions like recommending appropriate footwear or over-the-counter products, basic skincare, self-care can make a really big difference, especially for patients with financial or mobility barriers. Getting them the right information right off the bat can really set them up for success. It's also really important to set those expectations early on. Letting patients know what to expect from foot care services, what may or may not be covered by insurance or community programs, and what the typical costs are helps to prevent frustration and build a lot of trust with our patients. You can also direct patients to community resources. For example, local foot care clinics, diabetes education programs, funding supports through the agencies I spoke of. Many patients simply don't know they exist until we point them out. Another key piece that we just talked about was providing detailed referral notes. So when we as specialists receive clear information about the concern, the duration, and any attempted treatments or diagnostics already performed, it really speeds up triage and ensures that our patients get the appropriate appointments sooner. And finally, arranging routine screening for high-risk groups, especially those with diabetes, or any signs of neuropathy or limited mobility. Even a brief annual foot check can catch a small problem before it becomes a big one. And ultimately, it's about building a bridge between that early identification and the specialized care that the patients might need. We don't want patients falling through the cracks just because of access barriers or just lack of information. So foot care in primary care is important, and I know my opinion is biased based on my level expertise, but early identification and intervention significantly improves patient outcomes, mobility, prevention of complications, and in essence, quality of life. So knowing the scopes of practice of the different clinicians and providing some specificity and direction in your referrals can really expedite delivery of care. Pedorthists, chiropodists, orthotists, and wound care nurses each provide different areas of care. So matching the right provider to the right presentation in your patient really can improve outcomes and access. Detailed notes, including elements of the symptoms, the functional impact, other findings, and in cases of wounds, wound progression or details of treatment can support that timely and effective treatment and management. And addressing barriers proactively. So cost, transportation, awareness, and wait times are the main barriers to care. And primary care providers can help through early conservative management and making sure we're guiding those patients to those appropriate community resources and by providing that routine screening. At the end of the day, it's the interprofessional collaboration that's going to strengthen the outcomes. We want to coordinate care, make appropriate referrals, and engage the ongoing follow-up to improve access and reduce preventable complications. Footwear and orthotics play a major role in a lot of these complications, and simple education on proper footwear, activity modification, and use of appropriate offloading devices is central to management across a lot of conditions. So it's fairly universal that we can identify these issues early. We can usually slow them down or prevent them from getting to be much worse very quickly. And that brings me to the end of my presentation for today. So thanks so much for joining. I'd like to open it up to questions, of course. Specifically, is there anything you wish your community foot care clinicians knew or did more often? Or do you have any suggestions on how we can better or differently serve our patients?
And Kathleen, I just wanted to note there is a question in the Q&A from Patricia. I don't know if you can see that or you click the Q&A.
Not familiar with Teams. Let me look at that. Okay. Oh, yes. And there's one from Julie as well here. A list of local chiropodists, pedorthists, and RNs. So I try to keep up with the list of that. So that's a great question. I'd love to answer it. I'd love to have a resource readily available. It's ever changing. So I do try to keep a list, and I can check my list and make sure it's updated, and I can get that to Melissa to distribute. I'd be happy to do that. The Southwest Health Line is my main resource for finding clinicians if I don't know of someone in a patient area. In London in particular, I have a few favorites, but I don't want to play favorites. So I will make a list available to Melissa and get that out to you for sure. And the other comment from Julie is the plantar fasciitis exercises. Absolutely, we'd be happy to provide that. We can provide digital copies and hard copies for anyone, any primary care office, anywhere. Okay. Did I answer that question? Hopefully I'll answer both those questions properly. Any other questions or comments? Just looking at that chat, perhaps. Oh, well, you're welcome, Patricia. I'm glad you enjoyed it.
Yes, well, thank you so much, Kathleen, for being here today, and we'll get the recording and slides out to the rest of our membership, so that everyone has availability. But thank you so much for your time and providing
Thanks
this
for having
information to
me.
us.
And I'll get those resources out to you hopefully by end of business day today, and then you can distribute those accordingly as well.
Awesome. Thank you so much.
Thanks. All right.
Thanks, everybody.